Hello, I'm Dr. George Lundberg, editor-at-large for MedPage Today, and we are in Chicago at the annual meeting of the American Medical Association. We're initiating a conversation series, and today we're fortunate to have with us Dr. Jack Lewin, who is the CEO of the American College of Cardiology, and we're going to be talking about cardiology and medicine and health system reform and whatever else might suit an appropriate conversation of this sort. So,
George, it's great to be here.
Well, I appreciate you agreeing to meet with us. I remember we did something like this like almost 20 years ago, and we were talking about how you were the health officer in charge of health department for the state of Hawaii.
Right.
And almost everybody had health insurance back then. Is that right?
That's right. It slipped backwards in Hawaii a little bit in the absence of national reform. But yes, Hawaii really went close to getting the whole job done by virtue of an employer mandate and then a wraparound program for self-employed, part-time employed, and people not covered by employment. Very impressive work, and something that didn't get noticed a whole lot by the rest of the country. It's almost like health, universal coverage was impossible, so it couldn't happen in the United States.
Yeah, but it did, and it was there, and
Yep.
You helped make that happen.
And there was all the same obstacles and all the same constituency problems to go through, but it did get me to be clear about the fact that occasionally you'd have the right alignment of all the constituencies. You could get something miraculous to happen. Well, we just had a rather surprising health bill come through Congress.
Yeah, are you high on it or medium on it, or what do you think?
I'm high on the idea that we are not stuck in the status quo. This bill's not perfect, and there's a lot that's not in the bill that we need. I mean, we need to figure out how we're going to incentivize quality of care, change the alignment between insurance companies, doctors, hospitals, and so forth to build a more efficient system and keep the innovation going. So the bill's not a perfect solution, but it does move the access agenda forward. And it puts on the table some of the things around prevention and coordination of care that needed to be there. And it does a lot of good things in terms of insurance reforms and so forth. It's progress, it's movement. And I'm glad that we're not stuck in the status quo.
Yeah, I am too, but the profession itself has to take care of some of these things.
Yes.
In terms of professionalism, and I want to read to you a brief segment from an article in the New England Journal of Medicine last December by Howard Brody, the physician ethicist at the University of Texas Medical Branch in Galveston. Reading this, it's short, but it's for you, and it's also
Good.
For our readers, and it throws a gauntlet for your organization and many like it. Mm-hmm. Howard said within this fairly short article that each specialty society should commit itself to appointing a blue ribbon study panel to report as soon as possible that specialty's top 5 list. And that top 5 list would consist of the 5 diagnostic tests or the 5 treatments that are very commonly ordered and performed by members of that specialty that are among the most expensive services provided that give the least current value to the patient. And that this top 5 list then from every specialty society should be created and acted on as one way that we can bend the cost curve back down. What do you think?
I'd approach it a different way, but I think the goal is right. Okay, we waste too much money in this country on services that are not producing more health, right?
Right.
So here's the way I would go at it, George. I think we have to measure everything we're doing to manage it.
We manage what we measure. Dennis O'Leary used to always say that.
Right.
Manage what you measure.
Okay, so the college has invested, we're spending $25 million just this year, every year, on the registries that we have up in most of America's hospitals. We have 2/3 of the stent and angioplasty data. We have 100% of the implantable defibrillator data. We have a good deal of heart attack and coronary artery disease data, and we're expanding that. What we need is the outpatient data. We need the data in the besides the hospital across the spectrum, so that we can give doctors back and hospitals back data on how they're doing, including when they're ordering tests that frankly are unnecessary, or that don't even meet the scientific standards we so vigorously work to create and publish.
Okay, well, how do you get them when the standards are there, when the controlled trials are there, and they show you don't need coronary artery bypass grafts for stable angina. you don't need stents for stable angina. How do you get this cash cow of all these hospitals and all these doctors to go away and do the right thing for patients that cost less money?
Well, or even to focus on the millions of patients who aren't even getting the services who need them.
Yes.
Who are legitimately, somehow through disparities out of the system. Well, George, this is a big challenge, but I don't think it's that difficult. I think we measure, we publish, we give people back feedback on how they're doing, doctors, hospitals, insurance companies, everybody in the process. And when we have departed from what we believe to be the best scientific evidence of the day, either by undertreating, overtreating, mistreating, or just doing too many things that don't produce any real measurable additional value, then we shine a light on that. Now, you know what I learned, and you know too about our physician colleagues. If you see that somehow you're actually not practicing as well as somebody else in your community, you're going to change your behavior pretty quickly. I'd like to do this in a way that actually that aligns payment incentives around improved quality, improved efficiency, rather than payment incentives for more volume of services. That's what we do now.
Well, it's got to change. I mean, the whole thing is volume,
yeah.
and once it's no longer volume, then it changes.
Well, here's the thing that is not. It's a tragicomedy here, but it is somewhat amusing. In the sense that I've got a number of cardiology practices, lots of them across the country, that are using this data and this evidence to provide better services. But the reason that I can't convince everybody else to do it is the people who do this get paid less. You see, the incentives are so messed up in this country.
Money.
They get paid. Yeah. So look, the point is, we've got the tools today to improve systematically the quality of care in this country.
Yes, we do.
And the irony is that when improving quality is the way we're going to lower the cost.
Indeed. Less is more.
That is going to be
less can be more, and the Dartmouth people have told us that for a long time, and yet we haven't changed all that much. But I'm very happy to hear from you a positive, optimistic note that with your kind of energy, intensity, data, bright shining lights, etc., maybe Malcolm Gladwell's tipping point will be upon us, and we'll then move it towards less cost, better quality,
we're there.
More access. That's what we have.
We finally live in a time when when we can apply information technology in addition to all the wonderful scientific technology we have to healthcare, and actually use the precious dollars we have more effectively.
Well, I'm very hopeful with the leadership such as yours and others that we're talking to, that not only can this happen, but perhaps it will happen. Thank you so much for being with us today.
Thank you, George. Let's get it done.
We appreciate it, and thank you for being with us. I'm Dr. George Lundberg, editor-at-large for MedPage Today, and we're completing another conversation